Hello, my name is Dr. Karen Muschler, and I'm a fellow in medical toxicology at the Rocky Mountain Poison and Drug Safety Center. I'm going to lecture today about chemical warfare agents that are the vesicants and the irritants. These are mandatory disclosures for the Mountain Plains Regional Disaster Health Response System. I have no relevant conflicts of interest to disclose. And so I want to start with a quick family overview because when we talk about chemical warfare agents, we're talking about a very disparate group of chemicals that all get kind of lumped together as if they cause the same thing, and they don't. And so this is kind of the family tree of these different agents here. Today, we're just going to talk about two of those peripheral branches of the tree, the vesicants and those riot control agents. We'll start with the vesicants. And traditionally, when people talk about vesicants, they talk about mustard first and then the other two agents afterward. But I'm actually going to do it in reverse because we know very little about the two other agents. Unluckily, we have some more experience with mustard agents in history. So the vesicants are a group of chemicals that are going to cause what I like to lump together the surfaces injury. And so what that means is that it's going to be your eye surface, your mucous membrane surfaces, and your skin surfaces. Pretty much anywhere that these chemicals are going to land, either as a vapor, as a liquid, that are going to cause injury. The chemicals are all pretty unique from one another, but they all get lumped together because the most overt clinical problem is going to be those skin injuries and those surface injuries. Thankfully, only sulfur mustard has ever been used in warfare. This is good because at least in animal studies of lewisite and phosgene oxime, the outcomes are quite terrible. So we start with phosgene oxime. And those of you that are familiar with other chemical warfare agents, phosgene oxime is very, very different in pathophysiology than phosgene, the chemical gas that people get exposed to not infrequently. Phosgene oxime was first developed in World War II, but thankfully never used. The Americans were actually one of the first people to develop it, and the shipment of phosgene oxime that was intended to be used was sunk at sea after the war was over. Phosgene oxime is a terrible chemical, and it causes almost immediate skin and mucosal membrane irritation. It causes almost immediate like blanching and like wheel and flare reactions to happen when it's used in animal studies. And then over the subsequent minutes to hours, you get progressive necrosis of all of those areas that are affected. So while we lump it together with vesicants, which implies blistering, this agent really doesn't cause blistering. It's an urticariant, and it's a necrosis-inducing urticariant. It essentially acts like you mixed an allergen with a terrible acid. And so it's kind of what we see in these lesions. And so this chemical causes reactions with the skin and eyes almost instantaneously. So patients are going to develop severe eye irritation like blepharospasm, really aggressive blinking, conjunctivitis, and pain with very minute exposures and almost immediately after exposure. It takes about 2 minutes for skin lesions to start to develop, and these at first look like wheel and flare reactions, so like hives if you've ever been unfortunate enough to experience a nasty skin reaction to an allergen. And then that progresses into respiratory compromise. Unlike phosgene, the gaseous agent that causes ARDS, phosgene oxime does not cause ARDS. The problem is all a tubes problem. So it is a conductive airway disease. And what happens is in animal studies anyway, the airways form pseudomembranes a la diphtheria, and you have obstructive issues in the airway because of all of that tissue death and necrosis. The only treatment we know of to date is removing people from the source and aggressive decontamination. And honestly, that's about all there is for this chemical. We don't have any known treatment options. There's no known human exposures for good or for bad to have any sort of research data for. And so we have to model it all from animals. And from these animal studies, that once it's set in, there's not much that can be done, unfortunately. Similarly, we're going to move to lewisite. Lewisite is, unlike phosgene oxime, it is a true vesicant. So what separates lewisite from the mustard agents is the fact that lewisite will cause immediate pain. And on board examinations and other classic test questions, the immediate pain is what segregates it from mustard. The lesions start to develop within minutes. And there are some similarities between the lewisite and the mustard burns, which is one of the slides later. But essentially, you're going to get the liquid or the vapor will be absorbed within a few minutes. You'll get an erythematous skin changes in about 30 minutes. and they'll start to blister and form big bullae within about 3 to 4 hours from their exposure. Similar to phosgene oxime is that you're going to get that pseudomembrane formation in the airways. And again, that's all going to be the conductive part of the airway. So upper airway, trachea, major bronchial tree. And it's going to be an obstructive issue from all of that tissue swelling and death in those areas. Occasionally it's been demonstrated to see something called lewisite shock from massive and rapid third spacing in some animal models. But thankfully, again, this chemical has never been used in humans. There was an antidote developed to lewisite. People have probably heard of it many times, BAL, British anti-lewisite, which is also dimercaprol if you're experienced with other chelators. And while this was developed by the Brits in response to production of lewisite by both American and German forces, luckily, again, lewisite has never been used in warfare. And so while BAL has had fairly decent medical success as an antidote and chelator since the development of these agents, lewisite has never been used in human populations. If you remember back to that first slide with those molecular diagrams on there, you'll notice that there's actually an arsenic molecule within lewisite. And so what's unknown is if the toxicity from lewisite is caused by arsenic or if it's another process. And the shortest answer is it's probably both. Arsenic tends to cause a lot of free radical damage and binding of your sulfur ions and various enzymes and proteins, causing cross-linking and disruption of normal enzymatic and cellular processes. And so lewisite seems to kind of do both. When it comes to management of this, BAL used to be available as a topical solution, and in some animal models of lewisite exposures, BAL worked well topically. It's not known to work great as an intramuscular injection as BAL is currently available to manage lewisite poisoning, but we don't have many other options, so it's still a reasonable choice, as well as some of the other chelators like DMSA that are used sometimes. So since I'm tired of saying I don't know, we're going to move into mustards, which is, for better or worse, something we do know a significant bit more about because of exposures previously in both World War I and World War II, excuse me, as well as the Iran and Iraq War in the late 1980s and early 90s. So mustards are, if you're also into chemotherapeutic drugs related to those, there's an impure sulfur mustard, which is coded as H, and there's pure distilled mustard, which is coded as HD. That is important for like other distinguishing things if you're looking at particularly like coded diagrams, or if you're looking at other resources that help you identify what the chemicals are. If they don't spell it out, that's what those letters mean. It was first synthesized in the 19th century. Nitrogen mustard was synthesized in the 30s, but it didn't really work well from a warfare agent standpoint, but it worked great for cancer treatment. So it's been shifted from an agent of terror to an agent of therapeutics. And so the nitrogen mustards were never used in the battlefield. Sulfur mustards, however, was responsible for more casualties, not fatalities, than any other chemical warfare agent in World War I, even though it was only introduced in 1917, so the last year of the war. This led to a mass casualty and resource distribution problem, which is where mustard is efficacious. It does not tend to cause death. It causes lots of disfiguring problems and resource utilization problems. It does this by reacting with sulfonium ions and your proteins. So it's very similar to how arsenic kind of reacts. This is a same but different, where it essentially causes cross-linking through all those different sulfur molecules. It causes cross-linking in proteins and peptides, RNA and DNA and tissue membranes. And so all of that cross-linking means a lot of things are not working. Predominantly DNA repair doesn't work. This is essentially the same process that we use nitrogen mustards for in cancer management. But here, since we're not managing a metastatic disease, we are, unfortunately, it causes a lot of skin damage. And so what happens again is that you're going to end up getting that cross-linking and alkylation of the basement membrane at the dermal epidermal junction that sort of enables an in situ inflammatory response that actually generates the blistering. This reaction can actually be seen from the mustard molecule itself. And because the molecule of mustard is used up in the process of the reaction, the actual toxin is very rapidly eliminated from the body. So it becomes non-existent within minutes. The toxicity has already occurred, but that fluid and the blisters and everything else that happens to the person is done before we can do much about it. Blister fluid and other things is non-toxic. So what happens for folks is very similar to everything else we've talked about, is you're going to develop skin and eye and respiratory system bullet and blisters hours after your exposure. And that's the nasty thing when it comes to sulfur and mustard, is it does not cause immediate symptomatology for people. So there's no warning sensation. There's no like inclination to run away from a gaseous source. It smells oniony, mustardy, and it's not necessarily unpleasant. So people don't leave. And as they soak up more and more of the chemical, they get larger and larger doses. A liquid droplet of about 10 micrograms of sulfur mustard will cause a skin blister. And absorption through the skin is pretty fast at normal ambient temperatures, but that rate of absorption and rate of reaction dramatically increases with heat. And so hotter environments, and especially people who are sweating significantly, i.e. people using protective gear to respond to a chemical incident, and or soldiers, other folks who are outside exerting a lot of energy to do whatever activity it is, as they're generating more and more heat, they end up basically making heat traps, i.e. your groin, armpits, other really sweaty areas. Those sweaty areas are actually the highest risk areas for mustard injury, because that heat and that wetness causes increased absorption of the mustard, which then increases that risk of that skin injury. Decontamination is thus very important to make sure people are focusing on those sweaty regions. So armpits, axilla, groin, back of the neck, to reduce the skin injury in those areas. Airway problems are, again, very conductive airway problems. People do not generally have parenchymal lung problems from mustard. So similar to the last two we talked about, is if we can keep patients ventilated, they will do usually better than they will from another like ARDS causing source. If you have a greater than 40% total body surface area burn, these are generally universally fatal. One of the funny things with mustard, though, is it's fatal later. And so this is a diagram I built to kind of go over the time course for mustard injuries. 1 hour after your exposure, you're going to start to develop some ocular irritation. And that amount of irritation and the amount of ocular symptoms correlate strongly with the dose. So a little bit will cause, again, like excessive tearing, conjunctivitis, maybe some mild pain. And the higher the dose, the worse those symptoms are. 4 to 8 hours after exposure, we start to see skin changes. So erythema, you might have some airway symptoms like a hoarse voice and coughing. 2 to 18 hours after exposure, the skin blistering starts, and it evolves slowly over days. And it usually continues to worsen over that time. Most of the skin injury is complete at the 24-ish hour mark after exposure, and overall symptomatology, so ocular damage, airway damage, skin damage, is going to be at its peak. And from that point, patients are generally kind of stable. They don't usually need a lot of aggressive TLC. There's nothing we can do to decon or to treat further at this point. And so kind of watch and wait. And then around day 5, the risk of death rises dramatically. And again, it is not a problem from the mustard compound itself. What happens is people are at very high risk of secondary bacterial infections from all of this disturbed mucosal integrity and skin integrity. Blisters usually start to slough and to break apart around this point as well. And so as there's all that fluid loss and then all of that unprotected skin, there's ongoing fluid losses and electrolyte problems. Around day 7, ocular symptoms tend to improve, and around the 2-week mark plus, there's slow evolution and healing of those skin wounds. In a case series published in the early 90s from victims of the Iran and Iraq War, some of this healing time took upwards of hundreds of days before the skin was completely back to normal. Oftentimes chronic pigmentation changes were seen, whether this is hypo or hyperpigmentation, sort of depends on what your pre-test or pre-exposure skin condition was like, but it lasts for a very long time. And sort of to compare and contrast here, lewisite, again, luckily has never been used in humans, but it causes an immediate pain. The blister tends to start in the center of a erythematous area and then then expands out to the middle. The blister fluid does contain some arsenic. They heal faster. There's a lower risk of secondary infection, and there's a lesser risk of ocular injury with lewisite. Mustard, on the other hand, is painless at first, and so people don't run away and get larger exposures with mustard. Blistering tends to start around the edges of an area of erythema. This is sometimes described as a string of pearls look around the edges of those like big splotchy areas. and then slowly coalesce over time. The blister fluid is non-toxic for mustard, and there's no secondary risk to treating peoples or providers with mustard exposures. It heals incredibly slowly, and most of the deaths are happening at 5 days plus after the exposure, and it's from secondary infections and not a true toxicity from the agent itself. And then mustard does carry a higher risk of permanent ocular injury. Sometimes it's seen as corneal scarring, sometimes it's other chronic problems, but it's not precisely defined who is at risk or why they're at risk. The vast majority of people do regain their eyesight over time, but not all do. So this is again lumped all together for the clinical management of these cases. Luckily, there is no human history of phosgene, oxime, or lewisite exposures. And so there's no clinical management recommendation specific for those. This has all been extrapolated from mustard. So decon should be attempted if it hasn't been done. But when it comes to almost all of these agents, the damage has been done to the patient. So really decontamination is more important to prevent it from being spread to other people. That is particularly of concern for phosgene, oxime, and lewisite. For the mustard, because that reaction happens so quickly at the tissue level, there's very little risk of whatever they have absorbed causing any more problems for them or for you. The damage has been done very quickly. However, it is difficult to assess their needs care-wise up front, especially for the mustard patients. They can, like I said before in those previous slides, it takes a long time for sort of those symptoms to evolve and develop. And so what they're going to need over the long run is hard to say. Essentially, long-term management is probably pretty reasonably done at a burn center or other facilities that have that capability to basically do wound changes and dressing changes and careful fluid electrolyte management and careful anti-sepsis management to try and keep people from getting sick. Once the damage has happened, the skin wounds are pretty similar to conditions like toxic epidermal necrolysis or Stevens-Johnson syndrome, where you just lose a ton of surface protected tissue, and that leads to all the secondary complications. Short-term problems tend to be respiratory problems. And so again, like a lot of it causes that conductive airway injury. And so if we can keep people ventilated and protected in that regard, we can usually keep them alive long enough to heal up. Even small exposures and small areas of skin injury can take a long time to heal. And so even minimally injured patients still might need a lot of care. Moving into the riot control agents, very similarly to our vesicants from beforehand, they cause a lot of surface injuries, so skin, eyes, and the respiratory tract. And similarly to the vesicants, it's very dose and temperature dependent with how severe a person's experience is. Unlike the vesicants, though, they don't tend to cause lasting sequelae. So they don't cause any blistering, they don't cause any known long-term effects, at least with short-term exposures. For some of these agents, there is some suggestion of chronic repeated high dose exposures being potentially deleterious, but those are at this point single case report level evidence. So our riot control agents are, again, agents that are incredibly fast in onset within seconds to minutes. They also wear off very quickly, so the symptoms end very fast. These agents conveniently subvert the definition of chemical warfare agents, so they are used within the United States by various law enforcement agencies against other peoples of the United States. This is in part because they're generally not very risky drugs. Most people who get exposed to them, again, will be fine in about an hour with no long-term sequelae. The one notable exception to this is if people have underlying lung disease, particularly obstructive lung disease, the amount of coughing and shortness of breath and rhinorrhea that these agents cause can be potentially harmful to those folks. These are the four agents we're using most commonly in the United States these days. There's some other historical agents that were more toxic that are no longer being used. But those agents are oleoresin capsicum, chloropicrin, chloroacetophenone. And if you have any friends or family members who are an American service member or in law enforcement, they have probably had experience with CS, which is O-chlorobenzidylene malonitrile. And you should ask them about it, how that time was. These four agents all cause fairly similar clinical effects. And essentially, when you are exposed to these, you get very intense mucous membrane reactions almost immediately. CS tends to cause very intense eye pain, conjunctivitis, aggressive rhinorrhea and sialorrhea. I mean, like a lot of spit and snot happening. People cough and you have a lot of skin tingling and burning sensations. Similarly, capsicum, which is for those of you who've ever done any cooking with hot peppers and then accidentally touched your eyes, you have experienced self-inflicted capsicum poisoning. Capsicum is that hot pepper, that capsaicin sort of spice that is, or excuse me, the capsaicin spice found in hot peppers that causes, again, very intense burning sensation. The unique thing with capsicum is that it's actually through a specific neuroreceptor in the skin that sensation happens, which is why, if you've played with hot peppers, you know that you don't actually usually end up with any skin injury, but that burning sensation is quite intense and quite prolonged. Methylchloroacetophenone, which is mace, is again very structurally similar to these other compounds, and it causes rhinorrhea, lacrimation, blurred vision, nausea, chest discomfort. One of the more unique things with mace is that some people do have some dermal hypersensitivity to it, so they can end up with slightly more prolonged skin symptoms than others. And then there's chloropicrin. Chloropicrin is actually quite neurotoxic when it used to be used as a riot control agent, but it's still of note because it is a very unique chemical in that humans are exceptionally sensitive to the detection of chloropicrin. Where we find it most commonly these days is used as a warning agent. So it gets added to other odorless and tasteless and non-irritating but toxic gases so that you have a sense of alarm when you enter a space where that toxic gas exists. Human sensory detection for chloropicrin is as low as 0.3 parts per million. So incredibly tiny amounts of chloropicrin will kind of irritate the mucous membranes of folks. And so luckily we don't use it as a tear gas, but it is helpful in some other protective regards these days. With all of these products, if you expose people repeatedly, they can kind of develop a tolerance to it. Some people are less sensitive to these compounds than others. And then similarly, some people are more sensitive, particularly those with, again, respiratory disease history or allergy history. They might be just a little bit more sensitive to that irritation. And so I'm lumping them all together now for some pre-hospital considerations with all of these agents. So vesicants and the riot control agents together. So one of the most important things when it comes to gases in an environment is that almost all of the gases we talk about from a chemical warfare standpoint are denser than air, and they all have some like funky chemistry to them where they are sensitive to different amounts of temperature and vapor pressure and moisture in the air. And so the shortest answer is that PPE is very important for any first responder in a potential chemical warfare environment. Because of these features, these gases and these compounds will slide into low-lying areas. If you think back to World War I, the trenches were particularly bad because it collected all of those gases in those deeper sections. The purity of these chemicals also significantly alters its chemistry. And so pure sulfur mustard has very different chemistry and kinetics than some of the impure sulfur mustards. And so it's difficult to tell at the scene what exactly the risk and benefits are going to be like because we don't know exactly what's in these compounds. The persistence of these agents is another very important thing to consider. And when we say persistence, that means essentially how long a chemical sticks around in the environment. And essentially, this is important for mustard because mustard is a very oily, viscous liquid naturally. And so if it's sprayed, you might have a very fine oil coat on many surfaces, whether it be vehicles, trees, plants, surfaces of tents and other equipment. And so it can then contaminate other people. So if you brush your hand along like a tent or a tree, you are now covered and coated with mustard. Mustard in the environment lasts for at least 24 hours based on some older research studies. And so that risk stays there for quite some time. This is not the same for things like riot control agents, things like CS gas and things like that. While they have some more persistence than others, CS in particular, again, if anyone has law enforcement or military experience, they've probably felt when there's a little bit of CS left on a gas mask or something, it tingles later. That tingling sensation is just, again, that skin reaction from the chemical itself. You don't cause any other problems, but you can still sense it at even fairly low concentrations. So being aware of that and decontaminating very aggressively and very thoroughly is incredibly important. Other lectures will talk about how to set up hot zones and have that very dedicated and directed decon. And for things like mustard, that is very important to make sure we're not contaminating secondary areas or contaminating a hospital after the fact. Just as a quick reminder, because it always comes up, anything that has been used in the process of decontamination, so the water that is used to wash people, the sponges, the soap, all of that is now potentially toxic depending on the chemical that's at play. So there has to be very dedicated and directed hazardous waste management essentially at these sites. When it comes to detecting one of these chemicals, and this applies for most chemical detection systems, it's very important to know beforehand what your detectors will actually detect. So if your detector is only going to detect 4 different chemicals, one is sarin, one is mustard, one is riot agents, they won't detect everything else most of the time. And so it's very important to know what tools you are working with to know what else you should worry about. Because if it's set up to detect sarin and someone sprayed Tabin, then that's a problem. Again, this is important because mustards and things like that don't have any of that warning smell or unpleasant experience up front. And so people tend to not run away. The riot control agents, essentially all the same things I just said applies, but the important thing with decon is usually having people do it themselves. So for a lot of these agents, if you increase airflow, so you flap your arms, you try and take off your clothes, you will decrease that exposure and decrease your risk of exposing other people. There's, again, usually not anything specific to do for these agents. Copious water irrigation is sufficient for actual removal of all these chemicals. We don't have much else to offer, unfortunately, for these. And so as long as you're keeping control of your water source after it's been used, there's not much risk once it's gone from the riot control agents. If you're interested in the subject matter, I highly recommend hunting down the textbook Medical Aspects of Chemical Warfare. It is published by the United States military, but it has excellent history, data, and other factors that are at play for all of this. Some more citations are included there. And of course, at any time, I'm happy to receive emails and chat more about this if you'd like.